will make each speaker will make his presentation between 15 and 20 minutes, and then there will be discussion with respect to questions and answers. So we're going to kickstart with our first speaker, Dr. Douglas Oko. Dr. Douglas Emeka Oko. Sorry, I have to bring his I have to bring his short profile. Now, Dr. Douglas Emeka Oko is a consultant neurosurgeon with the Nigerian Health Sector Reform Advocate. He's also an entrepreneur and change agent who initiated and is propagating the mantra, the Nigerian patients are worth it. I'm not going to bore you with all his details. We know he's a distinguished consultant neurologist, neurosurgeon, okay, and the CEO of Ashanti Graham Medical Company Limited. They are based in both Nigeria and the UK. He leads a dynamic team at several prestigious medical institutions in Abuja, including the FMC, the Nizami Hospital, and Citadel Medicals. So he's a well-grounded medical doctor. Of course, his education started in Benin City. He attended primary, secondary, and eventually the great University of Benin, where he studied medicine
Yeah, so
and so.
greatest Uniben.
Yeah, congrats, great Universe. So by the way, he's my classmate. That's why
Yes.
he's excited that I'm reading his profile. Yeah, he is the co-founder and chair of the Ashanti Graham Health and Education Initiative Foundation. Like I said, I don't want to bore you, but I think the most important organic mantra, which is so dear to him, is that the Nigerian patients are worth it.
Yeah,
That's
so
why
the Nigerian
when
patients
we
are
were
worth it.
talking about health equity and access, I said he must be the person to speak. So join me to welcome Dr. Douglas Emeka Oko to talk on on the topic. He's going to talk on the sorry,
Universal health coverage, yeah.
yeah, he's going to talk on the topic universal health coverage. So be ready to ask him a lot of questions. He's a scholar. When I was in school, I fear him, but let's not expose ourselves. All right, welcome, Doctor.
Thank
The
you, Dr.
Yeah,
Kenneth Unkuma Uda. Thank you so, so much. You were almost calling me Peter. So just to let everybody know, there was a classmate of mine called Peter Konubo. We're always together. So that's why Dr. Unkuma Uda is actually almost made a mistake that called me Peter. But thank you very
okay,
much.
sorry.
Thank you to African Network Professionals, ANoP, and also Engineer TV that is actually running this. Like, if you don't mind, Dr. Nkuma, I'll just call you Kenneth. So, like Kenneth said, yeah, we actually went to the same medical school, University of Benin, graduated together. Before, at some point, I moved to the United Kingdom and did my training to become a brain surgeon. And after that, moved back to Nigeria. And the reason why I moved back to Nigeria was that I'm really passionate about how we can actually reform and push forward the delivery of safe and quality healthcare to Nigerians. And I suspect that that's why African Network of Professionals has actually invited me to talk here about healthcare equity, um, and stuff. So yeah, if I'm going to be, I have roughly about 15 minutes, isn't it? So I'll try and actually race through this if you don't mind. So the key thing, I'll start with some fundamentals. Yeah, I'm talking about universal health coverage. So the key thing is about philosophy. Okay, one of the key things I actually found out when I actually moved to the United Kingdom, okay, to train to become a neurosurgeon, was that I saw the difference in philosophy of what they have in the United Kingdom compared to where I was coming from in Nigeria. In the places like UK and other developed economies that we all know about, one of their philosophy, a key philosophy that they have is actually what we call value for human life. We don't have that in Nigeria. Okay. And I'm talking about a political philosophy. So we don't have that in Nigeria at this particular point in time. But clearly, philosophy and culture and values determine progress. Okay. They actually determine progress. So the key thing is that if we're going to actually move the needle in healthcare generally, and specifically in terms of healthcare equity, and this what I'm going to talk about now, universal health coverage. That means we have that culture, philosophy, and those values have to actually change. Now, guess what? We are in June 2026, and just in roughly about 6 months' time, we are going to go for a general election in Nigeria. Okay, so I guess it's actually timely that we're actually bringing this to the fore. So we now start talking about, okay, what are the general values when you internationally? Okay, so that's what they call the sustainable development goals. Okay, sustainable development goals means that for an average country, if you want to develop and make sure that a significant amount of your population, okay, a significant amount of your population are doing well, you try and focus on those 17 goals that you talk about. Okay, now there are 17 of them. Now, if you start counting from number one, number two, you start seeing about things about when you talk about tackling hunger, talking about tackling poverty, and by the time you go to number three, guess what? What's number three? Number three is healthcare. Number three is not roads. Number three is not bridges. Number three is not even electricity. Do you understand? Number three is not some of these things that we really that they are also very important too. But those things that we talk about in Nigeria and stuff like that. Do you understand? Number three is not them. Number three is healthcare, and of course, number four is education. Okay, so when you gallop ahead, you now start seeing all the other things to talk about. So the key thing is that from a philosophy point of view, a WHO philosophy, which is an international organization, says that nobody is too poor to get care, especially basic health care. Okay, so now we now want to talk about universal health coverage, which means that okay, especially for because but I'm going to be really pushing for the for the foundational level of providing of healthcare. Okay, and that's basic healthcare. It's funny, people wonder sometimes, you're in complex healthcare, you're even quaternary care because there are three levels of care. Usually we add a fourth one, isn't it? So there's basic level of which is primary, there's secondary level care, and there's tertiary care. What I actually get involved in my everyday working life is actually quaternary care. So neurosurgical care and cardiothoracic care, which is the brain, the heart, and the lungs. They are quaternary care. They're even higher than normal tertiary care. But people always wonder, how come that you keep talking about basic health care when you actually function in tertiary and quaternary care? It is because of my understanding of how you can actually deliver governance and the goodies of governance to a people. So universal health coverage. Basically, you're trying to say, okay, especially in a country like ours, where the WHO, where the World Health, the World Bank is projecting that almost about 140 million of our people are struggling in terms of looking at multidimensional poverty. So what universal health coverage just states from a philosophy point of view is that, hey, you need to make sure that all these poor people, that at least from a basic healthcare point of view, do you understand? That you, like I said, nobody should be too poor to get at least basic healthcare. Okay, so it's all about how do you actually pull funds together? How do you pull funds together in a sustainable way where you can actually get traction and you can actually deliver at least some modicum of basic healthcare that has some fundamentals of quality and safety? So where do we start from? The first thing is about governance reforms. So in 12/12/23, okay, the 12th of December 2023, our present Minister of Health and Social Welfare and stuff like they launched they launched a program where they were talking about compact. They were talking about an issue of where they can actually get where they can actually provide You must create an organized care in such a way that it's well coordinated and well integrated. Of course, also from a governance point of view and institutions point of view, you start going down all the way, looking at Federal Ministry of Health, looking at parastatals under it, especially the National Health Insurance Agency. Okay, go down to the states where you start looking at the different health, social health care schemes in the states, and even down to the local governments where you start talking about community health insurance schemes. Okay, so one of the first things that you notice is that there's significant fragmentation. Okay, there's significant issues with political will. Okay, or political will to say, okay, let's structure institutions in such a way where we cut out lots of bureaucracy, where we actually bring the best people to manage things at these different levels, at national level, at state level, at community level or local government level, and actually integrate these things so these things work very seamlessly. Okay, almost like clockwork, almost like an orchestra. Okay, so we've struggled significantly with that for a very, very long time. Now, in this particular government, in the last 3 years, have they been able to get it right in terms of institutional reforms and coordination and organization? The answer is a clear no. Second thing we look at, okay, we look at the issue of funding and financing. Okay, because when you talk about that, this is actually the cocoa of the matter, or the main thrust of the matter, isn't it? You're talking about a universal health coverage, okay, and basically you're talking about money. How do you fund it? Okay, of course we have what we call the Basic Healthcare Provision Fund, which is supposed to be 1% of the consolidated revenue, isn't it? So the key thing from a funding and finance point of view is that you understand, a philosophy, you fund it like you mean it. You actually fund it like you mean it. Okay? There's a difference between having what we call audio announcements. Oh, we've disbursed a third tranche of 32 billion naira. Oh, for how many what do you call it, primary healthcare centers and stuff like that. So we have to actually tackle the funding. Okay, we all remember the 2001 Abuja Declaration, where we should be pushing 15%, okay, of our budget to healthcare. Clearly, we are nowhere near there. Now, remember initially I talked about the issue of philosophy. Okay, one of the things I say is that think right, act right, and spend right. So the thinking is your philosophy, your culture, and your values. What do you actually value as a people? What do you value as a government, as a federal government? What do you value as a national assembly? What do you value as a state government in 36 states, and of course the FCC administration? What do you value as local government areas, which are basically, apart from the fact that, okay, yes, we are trying to actually strengthen there's autonomy, financial autonomy for local governments and stuff like that, that in terms of the implementation, which is back to political will again, that we are struggling with most of these things. Okay, so again, I repeat this, fund it like you mean it. So the key problem, again, from a philosophical point of view, is that when you look at the sustainable development, I'm still in terms of funding and financing, when you look at the sustainable development goals, and you say that for any nation to actually develop, these are some of the things we must focus on. And those 17, they put them in terms of priority. And your healthcare is number 3. And yet you have at different levels, okay? Federal government level, you see a president that spends $150 million on getting the private jet. You see how much they spend on vice president's lodge. Okay, you see how much if a federal capital territory administration will spend on what they call it, on an international conference center and stuff like that. And when you now look at your sustainable development goals, and you look at 1, 2, 3, and you see healthcare, and you see number 4, education, and you now go to the same FCT administration, where somebody spent almost 40 billion on an international conference center, okay, and you now look at the primary healthcare centers in that place, you look at the primary schools in that place, okay, you now go back to the issue of think right, act right, and spend right, and act out the philosophy of the thinking of those kind of places. We can extrapolate that. Okay, a significant number of our states in Nigeria, okay, go and look at most of our states. You find out that a significant number of the states have actually invested in airports, okay, okay, with funds averaging roughly somewhere between 15 and 35 billion naira, Okay? And you now ask yourself, how many of these airports in Nigeria really carry mainstream traffic? Okay? Port Harcourt, Enugu, Port Harcourt, Enugu, Kano, Abuja, and Lagos take about 80 to 85% of the domestic flights in Nigeria. But I'm telling you, there are up to at least 20 of these airports littered around Nigeria where nothing significantly happens. Now, if you go to those states where they spend these billions on airports, go to the primary healthcare centers, go to the primary schools from a sustainable development goals point of view, and then you see where we are struggling. Again, what did I start with? I said philosophy, value for human life. Okay, and of course, I linked it in with the fact that we're in political season, and what we're going to be listening to the politicians at different levels and the analysts at different levels, the political analysts, the economic analysts, and stuff like that. What we're going to be listening to them talking about. Okay, so from a funding and financing point of view, that is where we struggle. Okay, again, I'll repeat this: fund it like you mean it. Okay, now let's go to the service delivery point of view. Okay, now again, I just reminded you, World Bank projecting 140 million multidimensionally poor people. Okay, and of course, if you look at from when this government actually came in, okay, from when this government actually came in till now, and you look at, for example, the cost of just basic medication. We've run into very big trouble with what we call non-communicable diseases, diabetes, obesity, hypertension, apart from the infectious diseases that we're struggling with earlier on and stuff like that. Okay. Now, a significant number of the population, when you look at people who are from 40 going upwards, and especially the elderly population, are struggling with these things. Go look at the cost of drugs, antihypertensives, drugs for diabetes, and see how significantly expensive they are. Okay. Now, the key thing is that from a universal health coverage point of view, from the point of view of saying, oh, let's fund healthcare, from the point of view of pooling resources for healthcare and stuff like that, okay, you have to be bottom heavy and start from the foundation. Okay, again, basic healthcare. That is where our universal health coverage and funding should actually be mainstreaming our basic healthcare system, our primary healthcare system. We have roughly about 9,000 wards in the 774 local governments. And so one of the key pushes should be a situation where, from a service delivery point of view, that should be where we actually focus this pool of funds. Do you understand? Again, the key thing here is political will, the money itself in terms of pushing the funding, and I'm going to add a third one, accountability. Extremely important. Okay? So we should be very bottom heavy in terms of service delivery at the basic healthcare level. And the reason is simple. It is because you have a significant number of people who are too poor to be accessing secondary level care or tertiary level care. It is better to have a preventive healthcare setting or a promotive healthcare setting that prevents a significant number of that 140 million people who are multidimensionally poor from actually getting to a point where they have to actually access secondary, especially tertiary care. Okay, and I'll give you a very raw example. If you had in your ward, okay, in your local government, you had a primary healthcare center that was delivering on its promise of just the fundamentals of basic care. Okay, your grandmother goes in there. You understand? They have all the basics in terms of actually making sure that they're actually seeing her and actually looking after her and preventing her from actually having hypertension, or even if she develops hypertension and diabetes, actually be able to do what we call secondary prevention, where they prevent her from having the complications, okay, of these kind of problems and stuff like that. You can prevent her from actually actually having a stroke or having a heart attack and actually getting tertiary level care. And let's look at the numbers, okay? Clearly, the amount of money you will spend for that elderly lady to actually get, tablets, every sort of 2 or 3 months, she's coming in, she has her blood pressure done, her blood tests are done, this and stuff like that. The amount of money you spend at that level will be nowhere near what I do in terms of tertiary care. When patients who actually have had a hemorrhage or a bleed into the brain from the stroke, when they actually come into a hospital, where they actually need emergency care, they need critical care and stuff like that, they spend on an average nothing less than 6 million naira. So with 140 million multidimensionally poor people, where are they going to be getting? Where is the average person who runs into trouble because your preventive care doesn't work? Where are they going to get 6 million naira? And so that's why when you look at indices And you start asking, oh, what is the what do you call it now? What is the life expectancy of the average person in Nigeria? And you start having figures like 54, when the world average is roughly about 74. Okay, so the services need to be really focused. It needs to be bottom heavy in terms of governance, in terms of funding and financing. It needs to be really bottom heavy. Okay, please, whenever you see your state governments pretending that, oh, we are going to build a world-class hospital and stuff like that, tell them that, hey, you are just playing to the gallery. We as Nigerians, as me from this state, we are not that stupid. We have some common sense. Do you understand? When you carry our resources and you say you want to be building big hospitals and stuff like that, and your primary healthcare centers that can actually prevent, do you understand, people from getting to that level and stuff and spending 6 million naira, 7 million naira, and stuff like that, and you say you want to build a world-class hospital. When you build the world-class hospital, where are you going to get the healthcare professionals from? So that is it. Then the other issue is about what we call the healthcare workforce. Okay. Now, for the healthcare workforce, please, ladies and gentlemen, healthcare workforce is not doctors. Yes, the doctor is the poster child in terms of when you talk about human resources or healthcare workforce, but there are other healthcare professionals. And in fact, one of the key things from a strategy point of view, in terms of this issue of, how you actually use these funds in terms of universal health coverage, in terms of healthcare equity, in terms of how can we actually deliver this care to that last man in that ward, in that village, in that clan somewhere. How do you actually deliver this care and stuff like that? You need to be a little bit innovative and do a little bit of thinking, okay? If you look at the population of doctors in Nigeria, you certainly do not have more than 50,000 doctors in Nigeria for a population of 240 million people. So if you expect that you're going to be able to cover your 9,000 wards in terms of, even if you put one primary healthcare center in each ward and stuff like that, you are joking. To actually cover all the primary healthcare centers, cover your secondary level centers that are supposed to be under the domain of the state government, and actually cover your tertiary centers as well, and other specialized centers. That's a big joke. Okay, so in other words, going back to governance again, and in terms of organization, the people who run our systems must put on their thinking cap. Okay, there's what they call workforce optimization. You must think about, okay, how do we now develop a workforce that makes sense within this struggle that we have? Okay, of course, the people say that when looking at the population, we need roughly about 350,000 doctors in Nigeria. Are you going to get that in the next 20, 25 years? No, you cannot, actually. So you now look at policies like tax shifting, okay, and task sharing. So, for example, if you look at the primary healthcare centers in the world, in the local areas, stuff like that, you have these healthcare workers that they call community health extension workers. You have the ones called pharmacy technicians. You have the ones called lab technicians and stuff like that. These are people that you can actually optimize their skill in what we call competence-based way. Okay, where you actually train them to have competence, not theory. Okay, one of the things I always say that if you look at the average neurosurgeon, for example, trained in Nigeria compared to me trained in UK, they know more big theory than me. But when it comes to delivering care from a competence point of view, you now start seeing struggles. Okay, so we need a situation where you can have this low-level cadre staff and actually optimize them and actually pull a lot of people. It's even a way to actually provide lots of jobs. Okay, so for example, from a particular local government in a ward and stuff like that, you pull enough young people from there and actually train them as community health extension workers. Okay, train them in such a way that they can actually deliver that basic healthcare, and then you actually have proper referral systems and proper support systems, and which then moves to the other one of using digital platforms. Okay, to actually support them. If you have a community health extension worker in a primary healthcare center, for example, okay, and is seeing a patient, and that patient is struggling, what will I do with this patient and stuff like that? You can have digital platforms where you can actually connect with a doctor, maybe a general hospital or something like that can actually give you guidance. You have digital platforms for that thing. Even your phone self, talk less of. Okay? And of course, we can now move to the issue of, well, this universal health coverage point of view and pulling these funds and saying, how do you actually push for health equity and stuff like that? You look at essential medicines. Okay? And that's one of the good things about how you can actually pool resources together and actually sit down. Two things. Sit down with those people who produce in places like China and India and actually see how you can actually move some of those things and coordinate where you can actually start producing some of these generic drugs. But clearly, you must have quality. Produce generic drugs and actually pool resources together. If you have the 36 states in terms of their social health government pulling resources together to actually buy these drugs. You're going to actually buy them cheaper. Okay, I buy them cheaper or produce them cheaper. Okay, so like I said, generally, these are just some of the things that I would say in terms of when you look at how you want to actually, in a country where you have almost up to 70% of the population being very, very, very poor. Do you understand? When you look at how you can actually, do you understand, make sure that universal coverage actually helps to actually make sure that you have health equity and make sure that nobody is too poor to actually get care. All I'm saying is that you must make sure that you understand that politics is extremely important because it's your politics that's going to actually give you your governance. That's why sometimes I ask, when I'm on different people, I ask people, how many of you have your PVC? How many of you have understood and connected the dots to actually know that the person you have as a president, the person you have as a governor, the person you have as a local government chairman, the person who's going to represent you in your constituency, in Senate, in House of Rep, and in what do you call it, the House of Assemblies, you see the councillors in your wards and stuff like. How many of you understand that the decisions that are going to make, their thinking, their philosophy and stuff like is going to actually affect, do you understand, something as fundamental as how you actually deliver healthcare or education? Okay, and of course that dovetails into the philosophy of think right, act right, and spend right, and actually seeing, do these people, the people who run our affairs, okay, even we that say we want to vote them in, do we understand what, in terms of prioritization of resources, in terms of when you look at, okay, well, okay, we have different things that we should spend money on. Okay, there's president's what do you call it, plane. There's a conference center. There are primary schools. There are primary healthcare centers. As well. Which one should we dedicate our limited resources to, and stuff like that? And of course, we now go to service delivery. This means summarizing and ending now. We now go to service delivery. Okay, we have limited amount of funds with a very large population of very poor people. How do we dedicate these funds? Okay, do we have state governments that build very nice, you have some blocks and plenty very nice building and go and commission it? Do you understand? Or do we say, oh, we bought a big MRI machine in this teaching hospital? Wow, very good job and stuff like that. Or do we say no? Let's focus these resources that we don't have. Let's focus them on in such a way that it actually impacts on people in the villages, the clans, those people who are in farming communities and stuff like that. So we actually provide some sort of healthcare that gives them the basics and prevents them from developing problems that make them to come to the tertiary level. Okay. Do we say, okay, oh, seriously, in terms of healthcare workforce, we cannot get 350,000 doctors. We cannot get the almost 1.5 million nurses that we need and stuff like that. Okay, but we can actually develop a strategy where we actually say, okay, let's pull young people from the different wards and stuff like that, and have institutions that can actually train them to be community health extension workers, actually train lots of technology, digital platforms, make sure that we use data to coordinate and control things and stuff like that. That is how you can actually move the needle in terms of truly this fundamental thing that we call healthcare. That it's, you understand, look at every developed economy, you understand. You cannot say that when you are providing leadership, political leadership, governance to people, and your healthcare system is as bad as what we have in Nigeria. And like I always say, the Nigerian patients are worth it. I'm a Nigerian healthcare reform advocate. You understand? And I'm saying that, man, in Nigeria, despite all the difficulties that we have, all the problems that we have and so forth, we can have governments at different levels who actually, from a philosophical point of view, understand the importance of healthcare and start throwing in what we need from a point of view of governance and institutional reforms, of funding and financing, of service delivery, you understand, of the healthcare workforce, and looking at the strategies that we can use, looking at essential medicine and commodities, and using digital platforms and making sure that we actually sync in our data. Actually, the last time I said it, just when they swore in this particular government at different levels, I said that a government that is serious about healthcare and providing healthcare for its teeming population and stuff like within 4 years, okay, can give you a basic healthcare system that the average Nigerian can be proud of and that delivers some semblance of quality and safety of care. Like I said, the Nigerian patients are worth it. I rest for now. Questions and comments. Thank you.
Okay. Hi, everyone. My apologies for joining late. Thank you very much, Dr. for this presentation. When a surgeon is talking, you shouldn't expect anything less than approaching the subject with surgical, right? Yeah, that's what we did. That's what he did. You know, everything sequentially arranged, so it can make a whole lot of sense, from philosophy to practice, and then charting the path for the future. Once again, Dr. Oko, thank you very much for this well layered presentation. Time for questions. He has requested time for questions, so please go ahead, comment questions. You can type if you can't open your mic wherever you are, but if you show up your hand, we'll give you the chance to make your comment and then ask your questions. Who goes first? Questions, please. We're all together in this. We're together in this. We're all heading towards the same goal, and I'm sure his points are clearly stated, how different levels of government can lead the charge in overall indicating that they have high value for the life of the Nigerian, high and mighty, wherever we are. So questions, please. Okay. There's a comment. I have a question. Yes, Dr. Zwabli, go ahead, please. You want to type or you want to speak? Open your mic. You can speak from where you are.
Yeah. Okay. Thank you very much for this brilliant presentation. I went in my country, Ivory Coast, a few months ago, and I saw that even the people have no, most of the people have not the possibility of going and pay the services for diagnostics, or even if you have a disease like a cancer, or you have a disease like something which is related to your heart, your lung, something complex, or if you have a renal problem, it's like a sentence of death, you see, because you don't have the mean for having some kind of possibility to heal themselves. I love the idea of people might have the possibility of having the basic healthcare. But when I see this kind of situation in our country, perhaps we have to do something to help for that. We have to make possibility of making healthcare affordable, or perhaps for these kind of people not paying much. So how do you, what's your reflection about the fact that some illnesses in our countries are some kind of sentence of death because people don't have the money or the power, financial power to face that?
Okay, thank you, Dr. Zwali. I don't know what the population of Cote d'Ivoire is, but clearly it's nowhere near Nigeria. Nigeria has a population of about 240 million people. Okay, 240 million people. I'm sure it's probably even more than that. And like I said, you're having definitely more than 140 million people who are multidimensionally poor. Okay, now if look at our country from a funding point of view. Okay, the federal government had to actually cancel what we call fuel subsidies. Okay, this government that came, they actually had to cancel because they said, oh, we were struggling with the amount of money that we're putting into the fuel subsidies. Okay, and we are struggling with our funds that we need to actually do things. So what I'm saying is that Nigeria is a low-income country. And if you look at this present government has borrowed lots of money to say, oh, we need this money to finance this and finance this. So we are struggling with funds. So the key thing now is now prioritization, isn't it? You have to prioritize. When you have 240 million people, okay, The strategy should be that, okay, let me do with this limited amount of funds that I have, let me do the most I can do for the greatest number of people. Does that make sense, Dr. Zwabli? Let me do the most I can do, okay? And so you now start prioritizing, okay? Because look at you're giving some examples. Cancer care, okay? Renal care. The person is already having renal problems and stuff like that. Healthcare for those kind of secondary and tertiary problems are extremely expensive, Dr. Zwabli. Very, very expensive. So if you now have a country where you're struggling with funds, you're choked. I'm sure even the federal government of Nigeria now, they have the way things are going, they might get to a point where even recurrent expenditure say, oh, let me even pay in terms of my wage bill. Let me even pay people for their salaries and stuff like that. In the next 2 years or 3 years, with the way things are going in Nigeria, they might start struggling with that. So all I'm just saying is that from a strategic point of view, okay, because you have so limited resources, okay, as a baseline in terms of, okay, let's start pushing universal health coverage and stuff like that, it makes so much sense that you do what you can do for the most number of people, okay? And what is that? It is basic healthcare. Now, am I saying that, oh no, let's forget about people who have cancer? So I'm saying that, okay, if you can actually prevent people from actually having cancer, if it's possible. So for example, look at, what do you call it, cervical cancer, for example, a gynecological cancer. Okay, if you can say, okay, can we have the young ladies actually having vaccines, HPV vaccines and stuff like that? All I'm saying is that your strategy has to be preventive. Okay, what is the major cause of kidney problems where people have to not be paying for high amounts, where they now have need dialysis and stuff like that? What are the main causation factors and stuff like that? You now plug that into your primary healthcare center. So all I'm saying is that you really have to actually put your resources to preventive and promotive care for two good reasons. Number one, you are a poor country. There's this thing that goes around that, oh, Nigeria, we are rich. It's just that. No. When you look at your population and look at GDP, US per capita and stuff like that, you are a very, very poor country. That is the truth. And so two things. Number one, promotive and preventive care. Push funds. First of all, prioritize those funds very well. Don't in a place where your primary healthcare centers are not working, the primary schools are not working, the roads are supposed to take people to their farms and stuff, like, you didn't focus your energies on those things, and you're doing, building nonsense things, forgive my French, nonsense things, airports that people don't use, the flyovers and stuff like that, okay? And second thing, you really prioritize your basic healthcare system. So make sure that you develop a system that focuses on, the basics, okay? Lifestyle, wellness things, what do people eat? What kind of water do they drink? What is their health and sanitation like and stuff like that? You focus your energies on those things. Now, if you now say, okay, we would still love to actually do things that will actually help maybe a few of these other people who are very poor and they get to the point where they have cancer and stuff, then you can have special funds for that. Special funds where people donate, the big men, it's part of the big banks and stuff, it's part of their corporate social responsibility. And so they have special funds like that. And target those funds here and there and stuff like that. So those are some of the strategies that I actually think about, Dr. Zwabli. Thank you.
Okay, thank you very much. Okay, Dr. Zwabli.
Thank you very much. Yeah, it's excellent. Thank you.
Good, excellent.
I have another meeting in a few minutes, so if you don't see me, it's because I switch on.
No problem. Okay, before I take the next question, I have something I've been wondering about myself, Dr. Okor.
Yes.
Now, is this an Africa-wide problem, or are there some countries in Africa? I'm asking because this is a forum. African Network of Professionals is a forum is an Africa-wide forum. So, are there countries where they're getting it right? So someone can point, okay, go look at this and this and that and see what you can borrow, or is it an Africa-wide problem? What's your perspective?
Okay. So clearly, remember when I started this thing, I talked about philosophy, culture, and actually stated very clearly that values determine progress. Okay. So if you look at different belts in Africa, so you have like the North Africa, where you have all the Tunisias, the Egypt, the Moroccos and Algeria and stuff, and then you go down to South Africa, okay, where you actually had the Caucasians, the white people that were spending lots of time with them and actually developing something, apart from the problems of apartheid and stuff like that. If you remove those two out, okay, and now look at the part where we call sub-Saharan Africa, okay, where you have most of the West Africas, the Central Africa, East Africa, and stuff like that, you see that from a philosophical point of view, this issue of think right, act right, and spend right, and value for human life is basically, if there was a value for human life index, for example, okay, and you look at it comparatively, that index will be significantly lower for these people, these belts that have actually cut out, the sub-Saharan African belt. And so you see a significant struggle when you look at the political elite and governance at this level in terms of actually trying to push and actually use resources, and in terms of the governance and stuff like that, institutional governance and stuff like that, how they actually push and actually look after the people in terms of the welfare of their people, looking at things like healthcare, education and stuff like that. Okay, so it's a general problem when you look at sub-Saharan Africa. If you look at the countries in the northern part of Africa and look at South Africa, for example, you can see that there's a significant difference. Okay, but even in this sub-Saharan Africa, there are some places you can actually pick out and actually give them a little bit of a thumbs up. Okay, Rwanda is one of them. Rwanda has almost definitely up to almost about 85 or 90% in terms of their social healthcare insurance coverage. Almost 90%. Nigeria is struggling with somewhere between 5 and 10%. Right? You understand? Even Ghana has pushed up in terms of actually enrollees. Looking at the whole population of Ghana, they pushed almost up to 50% of their population being enrolled within the social healthcare insurance setting. Okay, there was a day I was flying from Lagos to Abuja. I went for something in Lagos, and I was with a lady who is she's from Kenya. Okay, and we just got talking about the difference in the healthcare system in Nigeria and Kenya and stuff like that. And you could see that, yes, even though in Kenya they are struggling generally with the healthcare system, but you can see that in terms of that political will, that money thing, that accountability, especially to basic healthcare, they are light years ahead in terms of when you compare a country like Nigeria. Again, I go back to the issue. You understand? There are failures at different levels. There's failure at the political elite level, but there's significant failure, significant. You can see how I'm really stressing it at the level of us, in terms of when you look at the middle class and the professional class, in terms of actually really, you understand, trying to actually put, you understand, clearly from a thinking point of view of priorities of what's important, actually speaking truth to power, and just tell them, no, you understand, this is not it. I can tell you for free that if you have a governor, for example, in any of the states that says, oh, yes, we want to build the best hospital, big time hospital and stuff like that. There are many people within our group as professionals, as people who are supposed to be middle class, as people who are supposed to be the intelligentsia think tank. Now be hailing the governor and say, fantastic, you are doing a great job and stuff like that. I'm telling you. So there's so much compromise when it comes to that middle class political level. And I guess it's simple. Maybe number one, psychologically they're giving up. They're saying, okay, nothing good can happen. Whatever the governors, whatever the political elite do, we'll just follow them. Or secondly, they themselves are hoping that they can actually translate from being within the professional level to the elite, to the political elite level. And so when they see the stealing and the poor prioritization at that level, they're like, I don't mind me getting there. And when I get there, I'll just do the same, follow the same culture. So yeah, so just summary, the sub-Saharan Africa itself, there's a significant problem when you look at the philosophy and the value system in terms of how you actually provide governance to people. But yes, you have these few examples like Rwanda, and I talked about Ghana and then Kenya. I yield. Hello? Dr. Igbani, you're muted.
Hello? Hello?
Hello? There's a very good question in the chat box.
Hello there.
Dr. Igbani.
Hello, can I go ahead? Okay, Bani, okay. I'm not a Bani.
Okay, yeah, go ahead. I think he's struggling, but go ahead.
Actually, go ahead. Okay.
Got in here. Go ahead.
Okay, got in here. Yeah, I like listening them from the point I joined. I've listened and you know, attentively and carefully to some of the things that have been raised here. I think part of the serious challenge, like you have also mentioned, in sub-Saharan Africa, and particularly Nigeria, my state, my locality, and all that, is the non-prioritization by our leaders on issues about health. I don't think that we have had government that have really been prioritizing issues of health so much so as to be able to devote, a lot of funding to it. A situation where you go through a lot of communities, a lot of localities, there's no one single basic primary health center that can take care of little things like malaria, outbreak of, influenza, or any of these little things, measles and all that. I don't know what your group organization is doing in pushing some serious advocacy to it to enable government begin to live up to their responsibilities. Then corruption again is another problem, because sometimes even the little that is being done, you hear so much has been spent or is being spent, and you don't see the reality on ground. Which way do we go? It's a hydra-headed challenge that we are dealing with as a people and as a nation. Thank you very much.
Okay, thank you, Gotin AK. So the key thing is that, yes, we keep saying that, yes, for context, when I come to give a talk like this, I must actually give you some fundamentals of what the issues are, and then I'll start giving you some ideas and strategies of how we can actually pull out of this. And you yourself, Gotin, you've just also talked about some of the issues as well, some of the symptoms of this more fundamental disease, okay? But I want to bring up one thing. You asked one question, that what is your organization? So, and I guess you're talking about the African Network of Professionals, that what are we doing about it and stuff like that.
Yes.
Unfortunately, it is not a one organization thing, okay? It's not a one organization of some small people here just saying, no. It is an issue of, yes, let the advocacy go out. Let it start building up slowly and start pushing. And guess what? When is the best time for this advocacy and stuff like, including you yourself got it, okay? Because whether you like it, you have your own platforms. You have your own small platform. You have your own small area of influence and stuff like that. So the first key thing for a Gotin AK, for example, or for all the people within African Network of Professionals is, first of all, understanding. Yes, sir. You must first understand where we are, first of all. Okay?
I agree.
So that's why, for example, so if you don't mind, Gotin, let me read something from Ambassador Sir Abubakar Turawa. Yeah, Turawa. I think I suspect that he is silent. Let me read something from him, Gotin, and I'll tie it with answering your question as well. So he says, "Good day. Thanks for this wonderful presentation. You have made a presentation that almost makes me speechless and confused about how we can make an approach to address this matter, while we all know the problems are leadership. From your own views, what do you think we can do?" Which is what you're asking me, Godson. What do you think we can do? For example, look at some governors here in the north. They are spending a huge amount of money that we don't have, on building flyovers and underpass and they are in competition to do so.
Exactly.
They are in competition to do so. Thanks.
Yes.
But he's a biomedical engineer. So the key thing is this, okay? First of all, can we please understand something? That when you look at your politicians, your political elite, from federal level to state level and legislation across board, please don't expect any of them on their own to now say, I'm going to repent now. I'm now going to start behaving myself. When I become governor of this state now, I'm going to prioritize resources properly. I'm not going to be wasting and stealing money on building flyovers and stuff like that. I'm not going to look and say, okay, in Kano State, for example, in River State, for example, okay, well, how do I work these resources in such a way that impacts on the people, where within every ward, every clan, every local government, every village and stuff like that, they actually have access to the basics. How we go? How if you expect your average politician to do that, then you are making a big mistake. It's not going to happen. Okay, so how do you now do it? How we do it is part of what we are doing now. First of all, educate yourself. And I brought out a particular strata of Nigerians. And who are those people? I said the middle class and the professional class. The major problem is that this class of people, they are playing to the gallery too much. They are refusing to display some level of courage. They are refusing. Because here is the problem, okay? No matter the big Turanchi that I speak, the big English that I speak now and stuff like that, a significant amount of your population who are very poor, who are illiterate, who didn't go to school, who are struggling to feed and stuff, they won't understand what I'm talking about. They cannot at face value like this, okay? But if you now have people within the middle class, the professional class, within their own sphere of influence, who now understand and the fact that we want to actually say, oh, we are developed, it doesn't mean that we should be competing like people that are senseless with UK and Canada and say, oh, because UK, London has flyover, we must have flyover in Abuja as well. Because, oh, when you come to Sheffield or Manchester, they have this kind of thing. Oh, no, we must have them as well. Sheffield and Manchester and London, they sorted out their basic problems already before they started going to bridge. You can ask yourself as a middle class person, okay? You can go on AI, go on Meta AI or go on ChatGPT and ask, how did China move 700 million people out of poverty? And you now ask yourself, what did they focus on? What was their focus that they were able to move such people out and stuff like that? So when you now first educate yourself, you now understand, okay, I'm an engineer, I'm a lawyer, whatever and stuff like that, in the middle class, professional class and stuff like that. Okay, it is June 2026. We have 6 months to election. Okay, so what should when I go to my village and I'm visiting people and they say, oh, we have a town hall meeting, and they call and I say, oh, well, you come and speak and stuff like that. What are you going to be telling your people? What education are you going to be giving your people? Apart from the fact that I hope that you're actually asking them and telling them, hope you work in your PVC. What are you going to be telling them? What are you going to be explaining to them and say, oh, see, no, when the local government chairman or the House of Assembly member or the governors, people who are representing people who want to be governors, when they come to you to come and talk to you, what should you interrogate them? What should you be asking them? To the main thrust and discussion should be about, he's a Muslim, so we'll support him. Oh, he's a Christian, we'll support him. Oh, no, he's Yoruba, he's Igbo, that's why we'll support him. Because should that be the thrust of the discussion? And so that is where we are getting at. That's why you can see that, yes, we can all keep blaming the politicians and stuff like that. But I'm saying the missing link that can help take us out of this, guess what, is the middle class and the professional class. Until they become true to themselves, the middle class and professional class, all of us here in this one, until we become true to ourselves and use all our platforms, whether you like we are on our village WhatsApp group, we have social followers on Facebook and stuff like that. Use that to advocate for the key things that can enable lives in Nigeria. Okay? And let them know that, man, hey, do you understand? Whenever people are coming to actually talk to you and stuff like this issue, I'm sure you saw the video of someone putting 15,000 naira, say, calling one particular political party and say, hey, 15,000 naira, stuff like that. These are the issues. I am saying that, man, you all of you here, okay, and by extension, those who are not listening to us and stuff like that, we are not that helpless. We're actually not that helpless. We can use our platforms and use at least the level of influence that we have to actually educate those significant numbers of people who are very poor, who don't understand, who are ignorant. Use your language. Those people in your village who hold you in high esteem and stuff like that. Yeah? So for example, Ambassador Sir Abubakar, and stuff like that. Let people in your local village as well say, no, say, hey, when you see a governor coming to tell you that I want to do a flyover and this and stuff like that, tell them that no, we don't want that. We want these resources to be used for things that can actually impact on our people. We want to make sure that these billions that are going to spend on overhead bridges, like, no, let this money go to our primary healthcare centers. Let this money go to our primary schools and stuff like that. Okay? So that's my answer to Godson Eke and also to Ambassador Sir Abubakar. So in terms of what can we do? We are not that helpless. we're actually not that helpless. Because
Yes.
use your platforms, educate your people, let them know that when you have a country like, yes, our country is potentially great, okay? So it's about the people taking back their country, especially in this season that we are, okay? Please, can we please push for the professional class and the middle class to stop playing to the gallery? Because I'm on lots of WhatsApp groups, and when I see what they actually discuss, oh, this person cannot win this election, is from this place, and I'm like, what? So the political elite has failed us. The professional class and the middle class also want to follow as well. So I hope that helps with the answer of, what can we do? This is what we can do realistically.
Okay, thank you very much. Thank you very much, all our commentators. And then, Dr. Okor, thank you once again for your presentation. We appreciate it.
Thank you.
Now we are moving to the second topic on this roundtable conversation. And the topic is addressing social determinants of health. Our presenter is a venerable professor, Venerable priest of the Anglican Church. He holds a PhD in nuclear physics. Not too long ago, he presented the 81st inaugural lecture at Nnamdi Azikiwe University, Awka. He is also the director, Center for Radiation Protection and Dosimetry Research, also at Nnamdi Azikiwe University, Awka. So join me to welcome our next presenter, Professor Nzota Christian. You've seen his top profile. So we're giving space for him now to speak on the topic, addressing social determinants of health. Professor Nzota, please, you're not already unmuted, unmute yourself, and then go ahead.
Thank you very much, the moderator. I want to start by commending the last speaker. He has really hit the iron when it is very hot. I want to believe he has really spoken to power. I am talking on social determinants of health. What are these social determinants of health? They are those conditions that influence people's health and well-being. In Africa, particularly in Nigeria, these determinants play a major role in shaping health outcomes and life expectancy. The social determinants of health, they lead to demographic and epidemiological changes, which predispose the victims to a new habit and a new lifestyle. I would explain this in the course of this discussion. Social determinants of health in Africa, particularly Nigeria, include 1, poverty and income. Limited income affects access to nutritious food, clean water, healthcare, education, and safe housing. Poverty is associated with higher rates of malnutrition and disease. In fact, it is important for us to know that the average Nigerian is one sickness away from poverty or death. The second social determinant is education. High levels of education are linked to better health knowledge, healthier behaviors, and improved access to employment. Low literacy can reduce understanding of disease prevention and treatment. Access to healthcare, availability affordability, and quality of healthcare services vary wildly. Rural populations often face long distances to health facilities and shortages of healthcare workers. The last presenter has dwelt so well on this. There are so many primary healthcare centers in this country, but a number of them are not working. In fact, I wouldn't be wrong if I say that over 60% of these primary healthcare centers are not working. The ones working do not have the qualified professionals. You will see one doctor covering over 10 centers, which is not ideal. The fifth determinant is housing and living conditions. Overcrowding, poor sanitation, and inadequate housing increase the risk of infectious diseases. Access to safe drinking water and proper waste disposal is critical. Employment and working conditions. You will notice that unemployment and insecure jobs can lead to financial stress and poor health. Hazardous occupations such as mining and some agricultural work may expose workers to health risk. Food security and nutrition. I attended a conference not too long ago, and the discussion was on security. And people were talking of so many things about security and insecurity. And the soldier in the midst of the discussants said that we have been talking about human security. We've not talked about food security. It is a major weapon of battle. So you notice that limited access to sufficient, safe, and nutritional food contributes to malnutrition and related health problems. There are a lot of physical and environmental changes which exposes the population to pollution, unsafe water, poor sanitation, and environmental hazards. All these affect the health. They are climate related, no doubt, but events such as droughts and floods can increase health risk. There was this incident in Kogi and part of Benue 2 years ago when there was flooding. Different dangerous snakes came from River Benue, and so many people lost their lives because the venoms were not easily treatable. You have gender inequality. Women and girls may face barriers to education, healthcare, employment, and decision-making. Gender-based violence and unequal access to resources affect health outcomes. We also have social and community networks. Strong family and community support can improve health and resilience. Social exclusion and discrimination can negatively affect physical and mental health. We have political stability and governance. In fact, this discussion on social determinants include economic, environmental, and political conditions that adversely affect the health of the populace. So you notice that political stability and governance, they could impact negatively or positively on the people. And when you do not have a merry heart, you would invariably find yourself in a very bad health. When you have conflict, displacement, and weak governance can disrupt healthcare services and public health programs. Effective policies and institutions help improve population health. We have culture and beliefs. There are cultural practices and beliefs which can influence health behaviors, healthcare seeking patterns, and acceptance of medical interventions. So you notice that the major social determinants of health in Africa include poverty, education, health access, housing, employment, food security, employment conditions, environmental conditions, gender equality, social support, governance, and cultural factors. Addressing these determinants is essential for improving health outcomes and reducing health inequalities across the continent. I want to take another step forward to discuss the health outcomes. You see, we have a system where the health outcomes have become so very significant. I draw inference and data from the global burden of diseases, injuries, and risk factors. This was a study that was carried out between 2016 and 2021 by International Labour Organization. It's a household survey. And we noticed that the key health outcomes noticed are: one, disability adjusted life years. What does this mean? It's commonly known as DALYs. DALYX, DALYs. There are so many people, even when they are employed, but they have disability due to communicable diseases, maternal challenges, nutritional diseases, injuries, and non-communicable diseases, what we call the diseases of the rich: diabetes, hypertension, cancer, and all these non-communicable diseases. These are social outcomes sequel to the factors I had raised earlier. And remember I said earlier that the average Nigerian is one sickness away from death or poverty. There are so many people who are seemingly well off. They are seemingly comfortable because they are able to struggle through their bills. They are able to afford 2 or 3 square meals a day. But the moment they have a burden of sickness, particularly the disease of the rich, which would alter their lifestyle and habits, poverty sets in. And there is nothing anybody can do about it because there is no social coverage, no health coverage that would mitigate the effect of these outcomes. The next very unhealthy outcome is what we call the NEAT. You have many people not in education, they are not in employment, and they are not in any form of training. Labor organization, that is International Labour Organization, calls it NEAT. Not in employment, not in education, and not in any training. This value amongst the youth, well, generally in Nigeria, is embarrassingly high. There are so many people you find in the streets. They are not in any form of education. They are not in any form of employment. They are not undergoing any form of training. In Southeast, particularly, you have people who understudy others for one trade or the other. They are not in any form of training. So these are the people who are more predisposed. They are very vulnerable to peer influence and negativisms. It's also important for us to note that there are health risks. These groups, they have increased health risk because they are idle. They are not doing anything. Tobacco smoking, not just tobacco, they smoke anything smokable. They are involved in drinking, different levels of drinking. A number of them, the ladies amongst them who are not in prostitution, they are in their mother's house. You see somebody at 35 still in the parents' house, eating, sleeping, and watching television. They are overweight. A number of them, there are different levels of health risks they are exposed to, primarily because they are vulnerable. We call them the vulnerable group. And in this study, it was noticed that this vulnerable group constitutes over 45% of the population. And there is nothing anybody is doing about it. There is no attention because the education system has gradually eliminated some people. There are no Montessori schools. In Montessori school, you are trained in line with your area of competence. If you have a flair for electrical work, you have a training that would help you become an electrical engineer. Nobody will bother you with literature, with religious knowledge and all those. So our educational system is not structured to accommodate all these people. So I want to point out that the social determinants of health end up altering both the demographic and the epidemiological status of our environment. Thank you very much.
Thank you very much, Professor Nzota, for shedding light on these determinants of health as are common in Africa, particularly Nigeria. Okay. The audience, you've listened carefully, so this is the time for comments and questions. If you're not able to open your microphone to speak directly, please, you are free to type your message in comments. We'll be able to read it out. So here we are again, time for questions. Please feel free to raise your hand, then we can acknowledge you. There are 13 of us here. So who goes first? Okay, while we are waiting for hands, Prof, I have I need clarification, please. You gave the example of the practice common in the Southeast, where some persons, usually young males, undergo apprenticeship under under a master and learn the skills of the study trade. So, but I wasn't quite sure whether you cited that as an example of those in the NEET bracket or outside it. Qualified for this.
Yeah, thank you very much. There are different types of training You have the baccalaureate training. The baccalaureate training is what we have in our schools. It is a type of training that involves series of academic work, presentation of thesis, convocation, and graduation. But this type of apprenticeship training is not baccalaureate. The apprentice would come and learn from the master. It is one of the mitigation steps to high-level unemployment we have in our environment. Because of the inability of our system to accommodate all. When I mean unable to accommodate all, I mean there are factors that so many people cannot meet. Poverty has greatly made it difficult for so many people to pay their bills through school. And worse still, the educational system had been hijacked significantly by the upper class. The government schools are no longer adequate for the average Nigerian because the best teachers now go to private schools. The government schools are no longer
Okay, I'm not sure where this is coming from.
so every Tom and Harry wants to go to a private school. And the high cost of fees in this private schools, it has gone from nursery to primary to secondary. Now that private universities run PhD programs, there are one or two private universities that run PhD programs. They will struggle through arts and social sciences. But surprisingly, private schools now run medicine. They do medicine, they do so many things. You have a medical graduate, there will be no place for internship because the private schools, they would admit 500 medical students and they don't have any place of training. But that is not the discussion now. The point I want to make is that so many people no longer have access to good quality education. And to mitigate this, the alternate type of training, which is apprenticeship, non-baccalaureate apprenticeship training, now is coming into play. And it's been very strong economic factor, very strong social factor. It is now helping the system stabilize, bring some form of balance between the neat, not employed, not in education, not in any training, and the desire of the state. The desire of the state is that there will be stability. Thank you.
Thank you very much, sir. What that indicates is that at some point, if there can be some formalization of this system, maybe the UN or whichever body involved may want to draft it into anything. We're hoping. Thank you very much, sir. Then now let's go presenter to presenter. Dr. Okor post this comment. Just a minute, please. Okay, so yeah, great presentation, Prof. That's from Dr. Okor. And then he follows up with a question. What should local governments in the Southeast do about improving the local determinants of health? Sorry. Let me repeat. What should local governments in the Southeast do about improving the social determinants of health? That's what you call.
Thank you.
From
Yeah. Thank you very much. You see, the local government is the third tier of governance. You have the federal government, you have the state government, and you have the local government. The local government has its own allocation, has its own internally generated revenue. They have its own statutory ways of making money, increasing their revenue. It is expected that what the federal government cannot address, what the state government cannot address, the local government should address. Let us look at some of these social determinants of health. The first is poverty and income. We have said that the average Nigerian is one sickness away from death and abject poverty. Every local government, in addition to the statutory health, primary health centers provided by the state or the federal government, every local government should have a general hospital. This general hospital, number one, would give access to everybody in the local government. Number two, it should be a little more affordable. The cost of going to a teaching hospital and the cost of going to a general hospital cannot really be the same. And number three, it would increase the employment to the people. You will have some as cleaners, you will have some ward mates, you will have more nurses employed, doctors and all those. So the presence of the local government general hospital would greatly impact on the people, both in the area of income, in the area of education, because more people will strive to get employed. There are CHU centers everywhere, community health extension workers. These community health extension workers are intended to provide hands in these general hospitals. They are supposed to assist the trained nurses. They are supposed to be the ward mates that would assist in these places. So you notice that the presence of 17 general hospitals in one state would mean the employment of over 300 community health extension workers, assuming each general hospital would be in the village doing nothing, would struggle to get their O levels. They will struggle to do community extension work. And beyond that, there will be technicians and technologists from these training institutions. So the local government will bridge the gap on education, bridge the gap on income and poverty, create access to healthcare, housing and living conditions would improve because more people would now have now afford to pay rent. They can even build their own houses. They will have decent accommodation, better sanitation, and that would reduce overcrowding. Remember, I pointed out that these social determinants of health, they epidemiological changes. These demographic and epidemiological transitions, the state. So there are so many things the local government with fertilizers increase the food supply from the various farmers. They might be very small farmers, but collectively they will provide a lot of food for the environment. So the local government plays a lot of role, more significant than even what the federal government will do. Thank you.
Thank you very much, Bob, for shedding light on this aspect of the presentation. Okay. Any other comments? Taking the comments section. Okay. Yes, it's from Ambassador Sir Abubakar. Okay, Dwarawa. Okay, hope I got it correctly. Thank you, sir. I think the local government area autonomy will help a lot in addressing such issues, but the challenges are state governments that have hijacked local government allocations, leaving them with no power or influence to do anything good. In your perception, how do you suggest that local government areas should, I repeat, in your own perception, how do you suggest what local governments should do to bridge these wider gaps created by the state government? Prof, I hope you get the question. In the absence of funds that the state governments have hijacked, what can, in your perception, what can local governments do to bridge the gap? Paucity of funds, yet they're expected to help their people. So what should they do? What can they do?
Thank you very much. When Dr. Oko was presenting, he made mention of everybody get your PVC. The problem, there are three major problems we have in Nigeria. The problem of Nigeria is not really corruption. The problem of Nigeria is impunity. Everybody acts with impunity. The corrupt people, they steal with impunity. There is this impunity in governance that makes it difficult for people to conceptualize the right, differentiate between the right and the wrong. We have statutory duties and responsibilities. Because so many people do not know where the local government belongs, the powers are hijacked. The funds are diverted. The authority is now delegated. No, the local government has constitutional authority, not authority delegated by the governor, no. Everybody should ensure he has a PVC. On the day of election, that person that you think is sponsored, that person you think has a godfather who must do what his godfather says, you vote him out. If the person in the local government council is not monitored, directed, and led in the nose, he would do better. The funds that are due to the local government would invariably come to the local government. That way, you would notice that there will be some reasonable element of performance. It will no longer be, if you don't do this, I'll throw you out. It's no longer going to be the governor directing the local government chairman on what to do and what not to do. There are statutory obligations and responsibilities of the local government chairman. But because they are now strangulated, they are now handicapped, they can no longer do this. So the way out is for the local government chairman to know that he has a right to take a decision. For the local government chairman to know that the allocation to the local government is the right of the local government. For the local government chairman to know that he is representing the people and not the governor. He must know that he is not there because of the party. And secondly, I have been listening to most of the politicians, aspirant, presidential, gubernatorial, local government. None of them has come up with a manifesto to say, this is what I want to do for the people. The people should have the privilege of receiving manifestos to take a decision and say, this is what we want. And this person that has addressed this aspect is the person who vote for. The time of sentiments and tribalism should go, and you'll see better performance from our local government authorities. Thank you.
Thank you very much, Professor Risotto, for commenting on that. And then in response to that, the questioner says everyone should get a PVC. We like that. Okay. With that, we are moving on to the last presenter for tonight. The last presenter is our chairman of ANoP, and he's talking on the topic Digital Health Access for Africa. His name is Dr. Kenneth Nkuma. Let me give you a brief of his background. He holds a PhD in a medical doctor and clinical engineer who teaches at the Federal University of Technology, Nigeria. He studied diploma in electrical electronics from what is now called Bachelor of Medicine and Surgery, MBBS. I think that was that spent on Dr. Otto. Then he has a master's in Information Technology, Medical Informatics, the National European University, and then a PhD in Computer Science with special interest in AI in medicine. So where we're up to date, we focus on AI and digital medicine. That was from University of Nigeria. Right. Like I said, he's the chairman of African Network of Professionals. So, a big founder and member of this roundtable. So, I'm giving first to Dr. Kenneth Nkuma now to topic.
Okay. Thank you very much. Thank you very much. I'm unable to share my slides, so I will present anyway. The topic is digital health access for Africa. Digital health access for Africa. And many of us are, when we hear digital health, we are in doubt. World Health actually defined digital health as the use of technology to improve health, healthcare, and well-being. So what it means is that digital health involves anything that uses technology to improve health. If you're using stethoscope, that's the lowest level. That's technology also. Because before stethoscope came, we know that the physician will use his, naked ear to listen to the heart or the fetal heart beat of a pregnant woman. But as time went on, digital health became, you know, identical to the use of computers in medicine. That is computerizing healthcare. But the definition still holds that it is the use of technology to improve healthcare. So it means that whether it is the use of computer or the telemedicine, hospital information system, all those, they are all technology use. Now we want to look at the topic digital health access for Africa. So we're not really looking at digital health as a subject. We are looking at its access for Africa because our theme for this quarter is health access, health equity, and access. So anything we're talking about, we must look at how is it accessible? Is it affordable? Is it available? And all those things. So, but there's a paradox. Africa has a lot of young people, and Africa is dynamic, and it has a lot of digitally interconnected population. Yet it suffers from what we call pilotitis. That pilotitis means that there are countless of digital health pilots that fail to scale. That is, there is lack of interoperability. Okay, mind you, we're talking of digital health. So we're saying that presently Africa, digital transformation, Africa is undergoing digital transformation and is quite accelerated. So we have this window to reshape healthcare delivery in this era of digital transformation of Africa. So the core question is not really if digital health works or if digital health improves, healthcare. The question should be how do we ensure that it is equitable, it is inclusive, and it is sustainable. So that is why the topic digital health access for Africa is very important. I'm going to introduce us to a local technology that ABC Informatech have made, which is why we need to embrace it. Now, there have been a lot of digital innovations in Africa. There have been Zipline in Rwanda. This one is about the use of drone to deliver health in remote areas. There has been MTBA in Kenya. It's about mobile health insurance. There's also DHIS2 that operates in more than 40 countries for real-time data. So all these things represents islands of success in a sea of unmet need, because they are pilots and they hardly, progress beyond the pilot phase. And the reality is that about 40% of digital health pilots fail to scale. They are not sustained. Even when you have them in various countries, you cannot interconnect, and they are not interoperable. Okay. So pragmatic systems that don't talk, to each other is what we have. That's why we were talking about pilotitis. Anything itis in medicine is inflammation. So it's a disease. So this is lack of interoperability. And many digital and health interventions have, come around, and they have been designed in the foreign countries, in high income countries. And when they come to Africa, they fail because the context of Africa is different from where it was designed. So it is not about innovation. So innovation is not the bottleneck, it's the implementation that is the bottleneck. So we need a digital health in Africa that should originate in Africa. So that's why I said we design for Africa, not import to Africa. So we should design digital health for Africa. We should not import digital health to Africa, because most of the digital health devices or systems that we have seen in many African countries were designed outside Africa. So they are not, they didn't take the African context into consideration. So you now have challenges of importing African digital health to Africa, like digital literacy. By the time it comes, it will take another period for training. There is also device access and even language barrier. So we have a solution, what we call the ABC Telemedica. It's a multi-channel access. It uses WhatsApp, it uses video, SMS, and it has local support too. There's also this challenge of unreliable electricity, internet, and hardware graveyard. We also have a solution for that. What about the AI tools that are developed outside Africa? We find out that they also lack representative African data. Those of us in uh, health data or health informatics, we know that when we want to do uh, designs using machine language to predict diseases, we find out that there are not much African data. We end up, in fact, my students in photo, when they are doing machine language to predict maybe lung cancer for patients in the next 5 years, they eventually go to Europe or America to source for data, because Africans don't have that. We have data, but they are not structured. They are not, we find it difficult to keep information or data. So that is our problem. So because the data we use in our digital health in Africa are imported data, they are not representative of what African data is. So there's high bias, and it leads to invalid clinical decision. So we have this solution of ABC Telemedica that is about telemedicine, and ABC Hospitica that is about hospital information system. What they do is that they validate AI models on African database, very important. They also build share repositories for anonymized African data, and it also formed a center for local health priorities. So they prioritize uh, disease management, infectious diseases, maternal health, and so on. Now, what are the recommendations? Recommendations for inclusive digital health Africa. There are 5 recommendations I'm going to make here. The first one is that we have to prioritize equity. Our theme is about health equity and access. For government and health managers or health stakeholders, there is need to invest in digital public infrastructure, the type that will serve the poorest, not just the wealthiest, because you find out that some of the telemedicine apps or systems are configured for wealthy people. But the one we are introducing, you know, is affordable. With less than 1,000 naira a month, you can access health, online. And even the doctors uh, also assess their patients online through that uh, means. The second recommendation I make about inclusive digital health Africa is for government to invest in infrastructure. We keep talking about poor electricity, poor internet connectivity. These are very important. Okay, you find out that a lot of companies in Africa, they run a lot of expenses in energy. They keep on using, you know, fuel, petrol for their generators. Even those that can afford solar power, they end up paying a huge sum of money to maintain electricity. And then internet connectivity. In Nigeria, Glo, MTN, sometimes they are not reliable. I'm sure you're also witnessing it. Some of the speakers and discussants are not able to, flow fluently because of the internet poor connectivity. The third recommendation is to strengthen ownership. Strengthen ownership. I know that there was a time Nigeria did indigenization policy, but gradually some of these systems and some of these companies are being retaken by foreigners. Okay, so we can only stop brain drain of skills, by training our local technicians and researchers and empowering them so that the the medical apps that are designed come directly from Africa, designed by Africans in Africa to be used by Africans. And that is the import of this presentation. The fourth recommendation is to develop sustainable financing. Africa should be able to move from donor pilots, to government and insurance integrated budgets. A lot of, even for medical equipment, there are a lot of donor equipment that are not, some of them are even 20 years outdated in the countries they are coming from. But because the uh, Western world, they don't pay taxes. In fact, I understand they receive rebates. They receive some funds for donating to charity because they say they are donating it to charity in Africa. So they keep on, sending their unused and unusable equipment and technology to Africa. So we should move from those donor pilots because they are not configured in our environment. So they are not going to work in this environment. The fifth recommendation is to foster regional collaboration. We Africans need to harmonize regulations across African borders to be able to, you know, allow solutions to scale continentally. Because if an app, a medical app like telemedicine app that is used in Nigeria cannot be used in Ghana or Egypt or South Africa, then it's not a good thing. So there should be regional collaboration. Having said that, I want to formally introduce our solution, ABC Telemedica. I've already posted it to our official WhatsApp group. So after the program, you just look at it. It's for everybody, the patient, the doctor, whether you have hospital or not, you can make use of those apps. So we're introducing ABC Telemedica. It's virtual care for all. So it is designed by Africa for Africa. That's why it is a big deal, and it's not imported to Africa. So it validates AI models on African data sets. So we want to start, uploading and piling our data sets. Data on, like Dr. Oka is a neurosurgeon. We want to have a lot of information about people's CT scan, brain CT, so that we can have access or we're able to predict whether such person can suffer, you know, any brain injury or brain disease in the next 5 to 10 years. It also has multimodal access. So you can access it in your village. You can use WhatsApp, you can use voice, USSD, and there are app interfaces that will help you. So it's accessible to everyone, and that is the purpose of this paper, because we want a digital health access for Africa. We want it to be accessible to everyone. It also employs AI-powered symptom assessor. So it can connect the users to journals, to medical doctors that will be able to diagnose and treat you online. So even if you're in Kafanchan and you want to see Dr. Oko in Abuja, you are able to, ask the app that you want to see a neurosurgeon, and the app will get you either Dr. Oko or his colleagues, and you just stay in Kafan. They will tell you what to do. You probably look for the next available CT scan center, and do a scan and post. And there you have your diagnosis. And when you now need to have a physical operation, then you can move. But even at that, as we develop, we need to also, develop robotic surgery that can be done from a distance. So on the long run, we need to bridge the gap between the average person and quality healthcare, regardless of the technology. We also introduce ABC Hospitica. ABC Hospitica is about strengthening health facilities. So if you have a hospital, you can evolve ABC Hospitica because it has electronic medical records, which is optimized for low resource settings. It has inventory management, which ensures reliable access to quality medicines because it reduces stock outs. It has clinical decision support that brings evidence-based guidelines to bedside clinicians. There's also workflow automation that reduces administrative burden overworked healthcare workers. And by the way, there's interaction between seamlessly between ABC Telemedica, which is a telemedicine app for continuity of care, with ABC Hospitica, which is a hospital information system. Now, to conclude, what is our collective responsibility as we close? We know that digital, or we should know that Digital Health Africa is not about technology, it's about people. Okay, it's about the mother in rural Nigeria who saves a day's wage by consulting a doctor via her phone. It's about the patient in South Africa who is receiving chronic care without leaving 100 kilometers. So we need to move beyond pilots to implementation. There are a lot of, digital health apps and, systems. We need to remove ourselves from pilots and start sustainable, digital health. So from imported solutions, we need to go to homegrown innovations. And the future of African health is digital. I want you to quote me. The future of African health is digital. And we must ensure that the future is equitable, is inclusive, and it is sustainable. That is my message this evening. Thank you very much.
Thank you very much for bringing roundtable tonight, digital roundtable, to very resounding conclusion. Thank you very much for coming. Right. Once again, I appreciate all of you professionals who have spoken tonight. You have you dove deep into your subject areas, you enlightened us, and you've also mapped out action pathways to get the problems that need to be defined. Yes, thank you very much. Comments right away. This is Dr. AK. I say with about 1,000 a month, one can access it in Nigeria. Please, Dr. Ken, is this for real? What is the quality of to be accessed? The destination of digital health equipment have local content is a welcome development, right? Thank you very much. Another comment: the digital platforms are the way to go. Okay, but Ken, let's go back to what Bottleneck is on. He appears to be surprised that with 1,000 naira you can have a month, you can have access to health in Nigeria. So is this for real? What's the response?
Yeah, it's for real. It's for real. We are talking about digital health being accessible and affordable. In fact, like I said, World Health Organization defined it as a process and the methods of using technology to access healthcare. And the very big aim, is to make health affordable, even to the rural areas. In fact, as far as World Health is concerned, digital health is for rural areas because they cannot, so many of them cannot afford the urban migration or travel to urban areas. So you can stay in your village with that app, with your phone. You just request for any consultant. Of course, that 1,000 or less per month is the registration. Just register with the app. There's consulting fee which the doctors will charge. Of course, we advise there is a maximum and there is also a minimum, value. But the important thing is that with that amount, you can access health because there are a few, health education in the app, before you consult your doctor. So it's not totally that 1,000, but we advise the doctors that are registering to also uh, place their consulting fee affordable. So it's possible. It's not a scam. Thank you.
Thank you very much. It occurs to me that the key word therefore is access. With 1,000 naira a
Yes,
month, you
the
have
keyword is access.
access to
Yeah.
help. So when they open the door, then you follow through with the real deal. Now, I'm going to what I'm going to find out. Let me see how many of us have heard it, and then I'm going to get my take on it. There was a meme or cartoon that was circulating sometime around last year that says the medical doctor you are going to rely on in the future is being trained by AI. Don't know how many of us saw that cartoon. I not have quoted it carefully. It was supposed to be a joke, implying that the medical doctor of the future is not it's not being trained like the typical medical doctor, but it's not being trained by AI. You know, and people laughed about it and they made all kinds of
Yes,
funny comments.
I
My
saw that
question is,
publication.
what's the future of medicine or healthcare delivery vis-a-vis AI? Is this something to rely on? Because people are divided. Some are discussing AI, others are, swearing by it that that's where the future. So, from your own experience, where are we headed?
Okay. Let me try to answer this from this point of view. Now, what is AI? AI just stands for artificial intelligence. What does it mean? It means that there are computers or a computer is mimicking the way human beings are thinking. And it's very clear. How do we form the database for the AI? In the design of the AI, we collect, in fact, I did my PhD was on medical diagnosis on the treatment of malaria, dengue fever, about 3 febrile ailments. What did I do? I went to medical doctors, collected information about malaria. A lot of medical doctors, because of course it was during a meeting, I will share my questionnaires to them. So they gave me information about malaria, how is it diagnosed, what are the possible treatments, over, of course you can use 1 million doctors, but you don't want to waste time and everything. So about, I think, between 20 and 30 doctors, or even 50, I can't remember because I did the collection more than once. And then I also accessed the internet, I also accessed the library and a lot of places. So what it means, let's assume we used 10 doctors to collect information about malaria. What it means is that if you're diagnosing malaria, your 10 people are diagnosing that malaria for you. So that's why we called it artificial intelligence, because they are now reasoning from the information of those human doctors. You know, that my system is called expert system. Expert system is an arm of, it's a branch of artificial intelligence. So it was expert system, you know, uh, for the diagnosis of malaria and other febrile illness. So what I'm saying is that artificial intelligence is really human beings intelligence, because of course that computer output you have is garbage in, garbage out. So what data or what information you give into the computer, like this doctor's information about malaria, is what you're going to get, which means you're still talking about human information or human information on malaria. Now, last year, during our Physicians Week, we also do paper presentations. Somebody presented paper about what happens to medical doctors when AI takes over. So we all agreed, it was a consensus by the medical doctors, that as AI is coming or taking over, you must also get yourself AI ready. It's just like saying somebody is not Y2K compliant. You have to be AI compliant. Okay? Of course, when you go to ChatGPT, any information you get, they also tell you that this is subject to blah, blah, blah. So you shouldn't take it hook, line, and sinker. What I'm saying is that in that conference or AGM, it was a consensus that as AI is coming, doctors that are AI compliant will not be driven away by AI. It's only doctors that are not AI compliant that will have to lose their job. So I hope I tried to answer your question. Thank you.
Thank you very much. Thank you very much. You did. Okay, Dr. Oko has 2 comments. One I'm going to read, the other one is going to make by himself. And it says the future of, by the way, he thanks you for this presentation. He says the future of African health is digital. It must be equitable, affordable, and sustainable. Great news. And he wants to make more direct comments. So, Dr. Oko, please unmute yourself and just comment. I would like to make a statement about two technologies and 1,000 naira. Interesting.
So, Dr. Ebani, thank you very much. And Kenneth, fantastic presentation in terms of all the strategies that you've talked about. The key thing is that when you look at using digital platforms in a low-income country like Nigeria, first of all, we're in 2026. So using digital platforms is definitely the way to go. And when you talk about the issue of health equity and look at things like affordability, accessibility, okay, accessibility is extremely important. So digital platforms are the way to go. Now, but the problem is, again, I go back to that thing I talked about earlier on, where I talked about the fragmentation. Fantastic job, Kenneth, that you guys are doing with this platform that you're actually pushing. But clearly, there are multiple people pushing different platforms in different places. Okay, that's one thing. Number two, even the culture and philosophy of being able for the average Nigerian person, talking less of the people in the rural area, to want to adopt these technologies in terms of using this thing on my hand, this phone, to actually adopt it, I want to actually access it and stuff like that. We are still struggling with that. Okay, what am I trying to get at? I'm trying to say that from the point of view of saying, strategies of trying to push things in terms of health equity using digital platforms, yes, tick the box, good. But from the point of view of, say, you want to scale in such a way that you truly make an impact in terms of accessibility of care, especially basic care and stuff like that, it's going to be a mega struggle. You can see I'm picking my words. It will be a mega struggle for individuals, private individuals, to get skilled. So, for example, Dr. Nkuma Uda and his digital platform that he's proposed and stuff like that, yeah, he can capture a few people here and there and stuff like that and everything. But if you talk of scale, because that's what people like me are interested in. If you talk about scale, where you have a significant amount of your population keying in and stuff like that, the foundation that you need to actually make that happen, guess what is who? It's actually government. Because now and again, this issue comes up, this question comes up. Oh, governments are not very good in terms of, pushing things. We need private people to come in and stuff like that. Do we need private people? Yes, we do. Can private people push it on their own to get skill? No, they can't. That is the truth. See, the truth is that if we truly want to develop as a people in Nigeria, the first thing we do is tell ourselves the truth. On the foundation on which private strategies like the one that Kenneth is actually pushing now, the foundation on which you can actually run and stuff like that is government institutions, first of all, buying into it, you understand, and providing the platform and foundation for it. You understand? There's a way we are wired as human beings. We are wired to actually really key into what a government, a political government actually does, more than private people. Okay, so that means that if you want to push these private things and stuff like that, it must rest on government as a foundation. And so if you want to, if you want to push it where you say, oh, for example, we have the people who are within the formal sector, isn't it? And if you notice, the National Health Insurance Act, for example, captures people more within the formal sector. So what we should be looking forward to is that what can governments do at different levels to pull in people with the informal sector? Because if you can pull those people in and you now start putting figures like 1,000 naira, for example, you can definitely look at our population. You can definitely rake in a lot of, because what you're trying to do is pull in resources. Everybody's not going to be sick at the same time. You're trying to pull in resources. And so, yes, the way you do it, you're pulling in resources. If you have, or in a community, for example, and that community, or let's say a ward, and in that ward you have maybe like 150,000 people. 150,000 times 1,000 naira. What are you going to get? That's a significant amount of money. But those 150,000 people in that community are not going to be sick at the same time. So if you have a significant number of people paying 1,000 naira every month, for example, in that community and stuff like that, you're raking in significant amount of resources. But of course, it goes back again. Clearly, that should be controlled by either the state government, local government, or whatever. But clearly, you now go back to the fundamentals again. Which average person in Nigeria is going to trust the average local government or state government and so on, and say, oh, these people are going to use our funds very well and so on. So it now goes back to the accountability that I actually talked about. So these are some of the things that we should actually be looking at. And these are some of the things we should be talking about. You understand? When they actually bring up political discussions and stuff like that, I want us to be talking about these things. Not talking about, oh, I like this politician. Oh, this politician is from my side. Oh, Igbo man was the president. Oh, see, we are making these things too basal. Okay? Then, again, if my grandmother, my village, who didn't go to school, he said, oh, I want a president who's Yoruba or whatever, stuff like that, I can understand that. But when somebody who's an engineer, a lawyer, an accountant is still speaking at that same level, man, we are in trouble. I rest my case.
All right.
Okay.
Okay. Yeah, you can respond now.
Yeah. I think he made a point. It's very important. It's very important.
Yeah. Okay. Thank you, everyone that has stayed with us in this moment. Well, serious issues deserve serious comments and serious investment of time. And I think that's what we've accomplished here tonight. I want to thank everyone, especially our presenters, discussants, Dr. Okor, Professor Nzota, and Dr. Thank you very much for the time invested in researching this, preparing these papers, and then standing by to clear our doubts and then answer our questions. Okay, so really having a father that's here. Okay, okay, good. None of us have stayed to the end. Some we are knocked out by effort and all of that. We appreciate all of these questions. Those who posted comments, we appreciate your contribution to make this roundtable lively and informative. Okay. Dr. Any comment from JJ, or we are okay to go? All right. I think we are drawing the curtain here now. So between now and the next roundtable, please stay safe. Let's do what we can to get the deal of progress coming forward. All right.
Okay.
Once again, my name is Dr. Mark Imani. I appreciate, please pardon me for logging in late. Technical issues here and there. Okay. So, final word, Dr. Nkumoda, please.
All right. Thank you very much. Maybe a vote of thanks. Let me vote thank you to all of us. It's not been easy. People have been coming and going, but many of us have doggedly stayed back. The recorded program is going to be pasted on our platform. That's very important. So if you are not already in the WhatsApp platform, or the Telegram platform, try and join so that you have every information. We also agree that we are going to make, the membership of ANoP was initially voluntary. We are going to make it a subscription type of membership. So just in the next few weeks, we will post it on the platform so that people uh, members, free members will formally register and join us. We are very grateful for you coming. Thank you, and God bless you as we go.